Good morning and a very warm welcome to each one of you on 78th National IRA Conference at Hyderabad. I'm deeply humbled and grateful by the opportunity given to me by the organizers, the chairpersons and the delegates. Follicular monitoring is a daily battle in our life. Follicular monitoring is not just about measurements, it's decision making. The slide basically summarizes our daily relationship with the follicles. We measure confidently at 16M follicle promises it will grow, Doppler makes us suspicious, and finally we are left with the most stressful question triggered today or tomorrow. Because in follicle it's not about the size, it's about timing, flow and the judgment. There's a brief overview of this presentation. I'll be touching upon embryology, physiology, ultrasound, physiology correlation, ART timelines and Doppler guidelines, key radiology takeaway and some clinical cases. The radiologist's role is very, very crucial. They are decision makers, they are not the technicians, because the precision matters. A 1 or 2 millimeter error or wrong day can decide pregnancy success, and the responsibility lies with us. Doppler is a gold mine which is an underused technology. We should be using it for follicular. Infertility is defined by the failure to achieve a successful pregnancy after 12 months or more of regular unprotected intercourse. It affects 15% of the couple. Ovulation is the cornerstone of conception and is the primary target. Ovulation is a normal process in which a woman's menstrual cycle releases mature egg from the ovary, and ovulation is the key for conception. Let's have a look at the physiology of menstruation. Journey to ovulation begins during late luteal phase of prior menstrual cycle, when 2 to 5 millimeter sized healthy follicles form a population from which the dominant follicles is selected for the next cycle. This is called recruitment. The number of such follicles may be 3 to 11, which goes on decreasing by the advancing age. I'll keep the physiology brief. We are radiologists, not the endocrinologists. During the day 1 to 5 of the menstrual cycle, a second process of follicular selection begins when among all recruited follicles, certain growing follicles of size 5 to 10 millimeters are selected, while rest of the follicles regress or become atretic. Day 1 to 5 is the follicular selection. Day 5 to 7 is the dominance. Day 12 to 16 is the LH search. During day 5 to 7 menstrual cycle, the process of dominance begins when a certain follicle of size 10 mm takes the control and becomes dominant. The follicle starts growing at a rate of 2 to 3 millimeter each day and reaches up to 17 to 27 millimeter size just prior to ovulation. One learning point in this regard is the largest follicle on day 3 of the cycle may or may not be the dominant follicle in the end. Almost nearing the ovulation, rapid follicle growth takes place and follicle starts protruding from the ovarian cortex, attains a cranial border and literally explodes to release the ovum along with some antral fluid. There are 3 A's of fertility: age, antral follicle count, and anti-Mullerian hormone. Ovulation was initially monitored by conventional methods like BBT, mid-luteal serous progesterone levels, and urinary LH level. Nowadays, USG is used for follicular monitoring for both natural and stimulated cycle. It has to be a serial TVS evaluation. Follicular monitoring forms a vital component of IVF and IUI. And timing. Why should we monitor the follicles? To assess the functional maturity of the follicles, helps in optimal timing and dose of HCG. It predicts the impending ovulation. It is used for evaluation if the dose being used is optimal. It prevents the over pickup during oocyte retrieval. It guides ovulation induction in an ovulatory cycle. It helps in avoiding excessive stimulation and prevents OHS and multiple pregnancy. It has to be monitored by TVS, transabdominal scan, misses 42% of ovarian details. It is real-time, repeatable, non-radiation, and it's a gold standard. Unlike routine pelvic scan, it's a dynamic, serial, comparative, and predictive. Serial USG monitoring starts from day 7 or 8 of the cycle. In case of gonadotropins, we start it from day 6 of the stimulation. The protocol has 3 scans: baseline scan on day 2 or day 3, pre-ovulatory scan, and secretory scan. Baseline scan is in absolute state where ovaries have no active follicles. It has estrogen, progesterones are at lowest level. Scan is of color Doppler, grayscale, power Doppler, and TVS. Baseline scan may we have examine the 2D assessment of ovaries, ovarian volume, diameters, antral follicle count, rule out any cyst. Follicle size is measured by taking mean of 2 longest diameters perpendicular to each follicle. Take inner wall to inner wall. Most mistakes happen here. Be boring, be consistent. Ovarian volume is easy to measure, although it's not a very good predictor of IVF outcome. A low ovarian volume does not always lead to an ovulatory cycle. but it is important to recognize the polycystic ovarian pattern arranged in periphery, forming a necklace sign echogenic stroma, and more than 20 follicles of less than 9 mm size signify a polycystic pattern in induced cycle, while follicles in the center as well as the periphery are seen in the normal induced multicystic ovaries. Ovarian classification on the basis of baseline scan, we can have normal ovaries, polycystic ovaries, low reserve ovaries, and poorly responding ovaries. Very important to predict the ovarian reserve and response so as to decide the stimulation of ART protocols. The antral follicle count is a surrogate marker of ovarian reserve. Precise counting of antral follicles is the best predictor of ovarian response to the stimulation. Antral follicle count 5 to 10 per ovary is normal, more than 15 is PCOS pattern, less than 5 is inactive ovaries, less than 3 usually signify the failure of ART. Count systematically, sweep slowly, and avoid double counting of antral follicle count. These are appearances of the follicles on stimulation day 5, day 9, day 11 and day 7 of the cycle, and on the day of ovulation induction the leading follicle should measure more than 18 millimeter, and we need to follow the sizes very precisely, and very important they are, because as I always say, we are the decision makers, we are not just the image readers, so it is very important to measure them precisely. Use of 3D in follicular mounting, it significantly increases the quality, enhances the accuracy and visualization, automation, speed, reduced operator dependency, and superior for high follicle count, especially for PCOD. Doppler use, ovarian stromal blood flow is a good predictor for ART success. Elevated PSV more than 10 cm per second is one such parameter. We have to assess the follicular maturity. Follicle, as I say, grow at the rate of 2 to 3 mm per day. A follicle measuring 18 to 20 mm has been found to contain a mature oocyte. Ovarian stromal blood flow, higher PSV, lower RIPI signal better follicular development, more oocytes, and higher pregnancy rates. With values like PSV more than 10 cm, RI less than 0.5 suggest imminent ovulation and hence good response, while poor flow less than 5 cm per second predicts poor outcomes. So, blood flow assessment using Doppler ultrasound in the ovarian stroma and within the perifollicular area. Key parameters are PSV. Higher the PSV indicates robust blood supply and good follicle health. RI and PI, lower values signify less resistance, suggesting increased estrogen production and the maturation. The visual cues to this is the high bright colors on the Doppler skin indicate increased blood flow with the brightest area chosen for the measurement. It predicts ovarian responsiveness, oocyte quality and quantity, and ovulation timing. The significance of this stromal blood flow measured early day 2, day 3 predicts overall ovarian reserve and response. Mid to late follicular phase, increased blood flow on dominant follicle more than 10 cm confirms readiness for the ovulation. Poor flow less than 5 cm associated with poor response and lower pregnancy chances. Doppler study to assess the vascularity surrounding the ovarian follicles. A PSV more than 10 cm per second is typically indicative of a mature, high quality follicle. RI, measure the RI to the floor. Lower the RI typically suggests follicle is receiving adequate oxygen nutrients. Vascularity grading on the basis of follicular circumference is surrounded by the color flow. Grade 1 less than 25% coverage, grade 2 20 to 50% coverage, grade 3 51 to 75% coverage, grade 4 more than 75% coverage. At this time LH surge starts, and this is the right time to give HCG trigger. Believe me, a red flag is beautiful 20 mm follicle with poor flow is a red flag. We need to be very cautious about it. Cumulus on ultrasound. The cumulus oophorus appears as a small, bright, hyperechoic mural nodule attached to the dominant follicle wall. It's inside the largest dominant follicle, and it's a small hyperechoic clump or nodule, often with indistinct border. Its significance is highly strong indicator of oocyte maturity and imminent ovulation, especially when clearly seen and dissociated from the wall. It can be subtle, sometimes missed, so be careful about it. So Doppler correlation with the physiology of ovulation. Early follicular phase, FSH increases the follicle recruitment. There is a follicle recruitment going on. There is high RI and PI. Mid follicular phase, day 8 to 11, dominant perifollicular RI PI starts falling. Pre-ovulatory phase, low resistance flow, and luteal phase, there is a highly corpus luteum, progesterone, luteum is there. So the key message is low RI and maximum perifollicular flow is imminent ovulation. Good flow plus low RI is ovulatory cycle. Poor flow plus high RI is anovulation or luteal defect. The sonographic signs of mature follicle are its round, fluid-filled anechoic structure having thin regular walls, sometimes a hypoechoic rim or cumulus oophoros is seen, increased perifollicular blood flow inside it. So key features are size roughly between 18 to 24 mm, well-defined, round, thin and smooth with sometimes may show some internal echoes, and increased vascularity in the follicular wall, often described as a ring of fire, indicates hormonal maturity. Features of ovulation: disappearance of the follicle. There is the presence of free fluid in the cul-de-sac and presence of hyperechoic smooth secretory endometrium. Endometrium is very important. It's a soil for the seed. It's a predictor of implantation. Perfect follicle plus poor endometrium has poor outcome. Optimal status of ovulation of the endometrium needs to be mentioned. Thickness between 8 to 14 mm. We have triple line. It should have clear hypoechoic halo. Junctional zone should be having clear hypoechoic halo. PI should be less than 3. They are very, very important to be evaluated, as follicle monitoring is important. Sometimes they are overlooked, but they are very, very important to be examined. There are few abnormal patterns in the follicular monitoring that we encounter every day. LUF, poor responders, hemorrhagic follicles, OHS. LUF syndrome occurs when a dominant follicle matures and undergoes hormonal change as if it were about to release an egg but fails to rupture. So it has a failure to collapse, has continued growth, sometimes reaching up to 30 to 35 mm, has internal echoes, wall thickening, walls become very thick and show increased resonance. There is an absence of free fluid which signifies LUF. Anovulatory cycles may have various ovarian findings. Absence of dominant follicle, there is no corpus luteum, there is a lack of free fluid, especially in the polycystic ovaries. The ovaries may show 12 or more small follicles and are increased ovarian volume. The endometrial findings may seek absence of secretory changes in the endometrium. There may be variable thickness because of unopposed estrogen, which increase the risk of endometrial hyperplasia. Doppler is very, very important at this stage. Higher RI in the ovaries and uterine arteries compared to the low resistance flow seen in ovulatory cycles during the mid-luteal phase, and there is a lack of vascular change. Typical ring of fire will be missing in anovulatory cycles. OHS is very important for us to know because there will be symmetrical ovarian enlargement, there could be multicystic appearance, Spokeville appearance, or maybe internal echoes. Endometrial thickness increases, triple layer appearance may be there. There is fluid collection in the pouches Douglas. Sometimes there is ascites and proliferation, and if there are more than 4 follicles larger than 16 mm or more than 8 follicles larger than 12 mm, it's best not to give the trigger so as to prevent OHSS and high order multiple births. We as a radiologist should be familiar with ovarian hyperstimulation syndrome so as to avoid the incorrect diagnosis of ovarian cyst neoplasm. OHS has a significant risk of miscarriage in early phase after IVF. Ovulation trigger, timing is the key. Goal is to identify the peak window for the trigger. The thresholds, gonadotropin cycles, the 18 to 20 mm leading follicle is the end point. For clomiphene cycles, the 20 to 22 mm should be the size of the leading follicle. The end point of any ovulation induction protocol is to identify the best time for triggering the ovulation. Now comes the secretory phase UH. The characteristics are: during this phase, 16 to 28 days of cycle, the body increases progesterone production to prepare the potential embryo transplantation. So there is a hyperechoic appearance, there is increased thickness of endometrium 7 mm to 16 mm, there is a loss of trilaminar sign, there is a posterior enhancement of the endometrium. Clinical significance: it has a normal reproductive health. Observing a secretory endometrium confirms that ovulation has likely occurred and the body is preparing for a possible pregnancy. Luteal phase defect: there could be an inadequate endometrial thickness. The endometrial lining may appear thin. There could be an abnormal echo texture of the endometrium. The lining may look patchy, uneven, unstable, indicating it is prematurely breaking down. The corpus luteum abnormalities may have reduced blood flow. Follicular growth patterns may be identified as small follicles or luteinized unruptured follicles in luteal phase defect. This is how I generally give a report of ovulation monitoring in my clinic. The day of the cycle, right ovarian follicles, left ovarian follicles, endometrial thickness, endometrial morphology, the Doppler values, and if there is any free fluid, and never forget to mention about any uterine abnormalities, maybe some fibroids may be there, ovarian volumes need to be calculated every single time, antral follicle count should be given so as to help the gynecologist so that they can plan for the trigger they want to give to the patient. So in a nutshell, ultrasound is the cornerstone of follicular monitoring, accurate, reproducible and clinician dependent. Transvaginal USG with systematic measurement is the key. Takeaways: serial scans are definitely preferred over a single scan because that evaluates the trend, growth rate, endometrial response. Endometrium is as important as follicle. Its thickness, pattern, vascularity influence the implantation potential, so has to be studied very, very carefully. Doppler adds value. Perifollicular and uterine artery flow helps predict the follicular maturity and receptivity. Recognize the red flags early. Poor follicular growth, premature utilization, LUF, ovarian hyperstimulation risk. Clear structured reporting improves the outcomes. Radiologist gynecologist communication is the key. We are not image readers, we are active partners in fertility management. In follicular monitoring, precision in imaging translates directly into precision in fertility outcomes. So structured reporting and clear communication improves the outcomes, as I always say. Please remember, we are not image readers, we are active partners in fertility management. I am really thankful for this opportunity, and if you have not subscribed my channel, do subscribe my channel. Thanks for watching.